Hi, my name is Alyssa, and this is Medisin, where learning is always in style. Today, we'll be talking about the electrocardiograms, or ECGs, of cardiac arrhythmias. By the end of this video, you'll be able to recognize normal sinus rhythm, identify cardiac arrhythmias from ECGs, discuss the pathogenesis of cardiac arrhythmias, and name the management for some cardiac arrhythmias. Before we start, make sure to like, comment, and subscribe. Also, follow our Instagram at MedisinStyle for more content on life as a med student and study review. Okay, let's get started. We have discussed the conduction system of the heart in several prior videos. In essence, it's the electrical system of the heart that coordinates the muscle contraction of each heartbeat. The system begins in the SA node, travels through the internodal branches to the AV node, through the bundle of His, the left and right bundle branches, and the Purkinje fibers. When this system becomes problematic, the heart does not contract properly or pump blood as required. Any abnormal changes in the electrical conduction are known as arrhythmias. In our last video, Intro to ECGs, we discussed electrocardiograms, which measure the electricity of the heart. Here on Medisin, we use a 5-point technique to assess an ECG, which includes the axis, rhythm, rate, intervals, and wave morphology. Check out this last video for an explanation on how to implement this technique. We also describe the features of normal sinus rhythm. This includes a positive QRS in leads 1 and 2, as well as a regular rhythm with a heart rate between 60 and 100 beats per minute. The PR interval should be less than 0.2 seconds, or one big box, and the QRS complex should be less than 0.08 seconds, or two small boxes. Finally, every P wave is followed by a QRS complex, and every QRS complex is preceded by a P wave. All this suggests that the heart rhythm is initiating in the SA node, in normal sinus rhythm. Any deviation from these features constitutes an abnormality. Today, we will discuss the following heart rhythms: sinus bradycardia, sinus tachycardia, premature atrial complex, atrial fibrillation, atrial flutter, heart blocks including first degree, second degree, and third degree, premature ventricular complexes, ventricular tachycardia, and ventricular fibrillation. Let's start with the sinus rhythms. All these rhythms begin in the SA node, which means they follow all the previously mentioned criteria of sinus rhythms, except for heart rate. Sinus bradycardia has a heart rate less than 60 beats per minute. This may be genetically benign for some people. However, it may also reflect an underlying pathology, such as decompensated shock, hypothyroidism, or opioid use. Sinus tachycardia reflects sinus rhythm with a heart rate greater than 100 beats per minute. While tachycardia in the setting of exercise is normal, tachycardia at baseline generally reflects an underlying pathology, such as an infection, hyperthyroidism, obesity, anemia, heart failure, or anxiety. The best management approach to sinus bradycardia and tachycardia is to treat the underlying disease. Now let's move on to the supraventricular arrhythmias. These are arrhythmias that begin above the ventricles. Therefore, they start somewhere in the atria or the AV node. Premature atrial complexes, or PACs, describe an early heartbeat that disrupts the regularity of normal sinus rhythm. This heartbeat includes a P, QRS, and T wave like other heartbeats. PACs originate from a group of pacemaker cells in the atria that are outside of the SA node. These are called ectopic pacemaker cells. PACs may sometimes be perceived as palpitations, but oftentimes they are discovered incidentally on ECGs. They can be caused by any number of things, like pregnancy and caffeine. Generally speaking, they are benign and no intervention is needed. Notice this premature atrial complex circled in red. It does not follow the regularity of the other heartbeats. It's early. However, it still has the P, QRS, and T waves of a normal heartbeat. Now let's move on. Atrial fibrillation, or AFib, describes a disorganized and incomplete contraction of the atria. In AFib, ectopic pacemaker cells are usually found near the pulmonary arteries in the left atria. These cells lead to a rapid depolarization of the atria that overrides the SA node. However, this is so disorganized that the atria never fully contract. Instead, they shake or fibrillate. On ECG, this translates to a lack of distinguishable P waves. Rather, there is a mess between each R wave. Moreover, the rhythm in AFib is irregularly irregular, which means the interval between consecutive R waves varies. This is a result of the chaotic messages received by the AV node from the atria. This is often perceived as palpitations by patients, but many people can be completely unaware that they are experiencing AFib. Since the atria in AFib never completely contract and pump out blood, there is a high risk for clot formation in the atria. If this thrombus dislodges or an embolus breaks off, it could lead to a stroke or pulmonary embolism. Therefore, patients with chronic AFib must be managed to prevent such cardiovascular events. Treatment generally includes a rate-controlling medication like a beta blocker. The CHAS-VASc score is used to assess a patient's risk of stroke from AFib and helps determine whether a patient should also be placed on an anticoagulant prophylactically. Risk factors for AFib include obesity, age, heart disease, hypertension, alcohol consumption, and family history. Look out for the Happy Holiday schema on your boards. This is a patient who classically presents with AFib after a celebratory night of binge drinking. Atrial flutter is similar to atrial fibrillation in that the atria are firing faster than the AV node can follow. However, atrial flutter originates from ectopic pacemaker cells in the right atrium that leads to a reentrant or backwards relaying circuit. I like to think of atrial flutter more like atrial tachycardia because the atria actually have a regular rhythm, but this atrial rate can be 250 to 300 beats per minute. Of course, the AV node cannot respond to each of these signals. Rather, the AV node responds with regular ventricular beats following a fixed number of atrial signals. However, this still translates to a ventricular rate as high as 125 to 150 beats per minute. On ECG, this leads to a sawtooth appearance of the P waves. For example, here we have two P waves preceding each R wave. The atrial rate is about 300 beats per minute, and the ventricular rate is about 150 beats per minute. Similarly to AFib, a flutter may be perceived as palpitations. It also confers an increased risk of thrombus formation in the atria, which could lead to a stroke or pulmonary embolism. Therefore, patients with chronic A flutter must be rate controlled with a beta blocker and possibly anticoagulated as per their CHAS-VASc score. Risk factors for A flutter include chronic pulmonary disease and heart failure. Now we will move on to AV heart blocks. AV heart blocks, also known as AV conduction blocks, describe an electrical block that prevents proper propagation of action potentials from the atria through the AV node to the ventricles. Think of it like a roadblock on the highway that causes traffic. There are three types of heart blocks. First-degree heart blocks are like closing one lane on the highway. Traffic still gets through, but slowly. First-degree blocks are characterized by a prolonged PR interval. Recall that the PR interval should be less than 0.2 seconds, or one big box. In first-degree blocks, the PR interval is longer than this. However, the prolonged PR interval is fixed, and every P wave is followed by a QRS. Therefore, you can easily confuse it with normal sinus rhythm if you don't measure your intervals. These are benign heart blocks that are often seen in young patients with increased vagal tone or in well-trained athletes. No treatment is required. Second-degree heart blocks are a little more worrisome, and there are two types. Mobitz type 1 blocks are characterized by a progressively increasing PR interval with an ultimately dropped QRS complex. The dropped QRS complex is known as the Wenkebach phenomenon. Causes include increased vagal tone in athletes, medications, and myocarditis. Patients are generally asymptomatic and thus not treated. However, if patients are symptomatic, then atropine or a temporary pacemaker could be used for management. Here we have a 12-lead ECG with a Mobitz type 1 heart block. Let's focus on lead 2 to really see the Mobitz type 1 pattern. Notice how the PR interval begins short and progressively gets longer with each consecutive beat. Finally, the QRS is just dropped, denoted by the pink arrow, and nothing follows that P wave. This is an archetype of the Mobitz type 1 or Wenkebach heart block. Mobitz type 2 heart blocks are characterized by fixed PR intervals and periodically dropped QRS complexes. This may lead to a regularly irregular heart rhythm. Mobitz type 2 heart blocks are generally caused by fibrosis of the ventricular septum, or wall between the two ventricles, following a septal myocardial infarction. These heart blocks always require a permanent pacemaker because they can progress to a third degree or complete heart block. Here we have a Mobitz type 2 heart block, again focused on lead 2. Notice how there are 3 normal beats, each with the same PR interval, followed by a sudden lone P wave that is not conducted into a QRS. These non-conducted P waves are emphasized by the pink arrows. This pattern is characteristic of Mobitz type 2 heart blocks. A third degree or complete heart block is a complete miscommunication between the atrial and ventricular contractions. In essence, the AV node is completely blocked, like a complete shutdown of all the lanes in the highway. Therefore, the SA node fires independently to contract the atria, and the AV node also fires independently to contract the ventricles. On ECG, this means that consecutive P waves are equidistant and consecutive R waves are equidistant, but there is no relationship between the firing of a P wave and the firing of an R wave. On the example shown, the arrows on the bottom in pink indicate the P waves, and the black arrows on the top indicate the R waves of the QRS complexes. It is important to note that sometimes P waves may be hidden within QRS complexes if they coincidentally occur at the same time, such as with the yellow arrow. Also, it is important to note that the P waves generally fire faster than the R waves because the P waves originate in the SA node and the R waves initiate in the AV node. The intrinsic rate of depolarization in the SA node is faster than in the AV node. Third-degree heart blocks always require a permanent pacemaker, unless the cause is reversible, like medication use. Finally, we can move to the ventricular arrhythmias, which originate within cardiomyocytes of the ventricles. Premature ventricular complexes, or PVCs, are comparable to the premature atrial complexes we discussed earlier. These are ventricular contractions that begin ectopically, which present on ECG as wide, dysmorphic QRS complexes, as indicated by the red circle here. Recall that the QRS complex should normally be less than 0.08 seconds wide, or 2 small boxes. Also, a PVC, by definition, occurs earlier than the next normal beat would be expected, so it disrupts the regularity of the rhythm. They are generally benign and cause no symptoms. In a young, healthy person, we just reassure the patient. In a symptomatic patient, we may consider beta blockers. Ventricular tachycardia, or VTAC, is defined as 3 or more consecutive PVCs. Therefore, this is a prolonged, regular rhythm of wide, dysmorphic QRS complexes with a heart rate greater than 100 beats per minute. We can think of this as organized chaos. These are obviously not normal ECG waveforms, but these waves do have a constant shape and a rhythmic regularity. In ventricular tachycardia, the ventricles are beating without prompting from the AV node. VTAC is so dangerous because it can convert into VFib, which is life-threatening. In a stable patient, VTAC is managed with amiodarone, lidocaine, or procainamide. In an unstable patient, we manage with synchronized cardioversion. In a pulseless patient with VTAC, we perform emergent defibrillation. Ventricular fibrillation is the most dangerous of the arrhythmias we have mentioned because it can lead to cardiac arrest. This is an emergency. In ventricular fibrillation, the ventricles do not fully contract. Rather, they fibrillate or shake. Therefore, blood is not propelled from the heart appropriately, leading to ischemia of the organs. VFib is a chaotic rhythm on ECG that just looks like a whole lot of nothing. If you see this, immediately defibrillate your patient. In summary, we have discussed many arrhythmias that you can find on ECG, their pathophysiology, and their treatment. Please be aware that this is not comprehensive. In fact, our next video will be on ischemic ECG changes and will include those for myocardial infarction and ventricular hypertrophy, as well as the pathophysiology for those difficult diseases. So stay tuned. That's it. It was a long video, but an important one. Please be sure to like, comment, and subscribe. Also, follow our Instagram at Medisin for more content. My name is Alyssa, and this is Medisin, where learning is always in style.